Welcome everybody. And I am very pleased to welcome you to this SDS Thursday with a special guest we've got today, and it is Deanne Jade, the founder and director of National Center for Eating Disorders. And this course came about through cooperation between Deanne and Paul, and Deanne came with a suggestion to Paul to run a special Socratic questioning workshop for working with eating disorders. And while we were discussing that course, we thought, why not invite Deanne to talk to you about various aspects of eating disorders. And that's how this Thursday came about. So I'll pass the microphone to Paul now to introduce Deanne more formally. And as always, if I ask you to keep your microphones off, but if you have any questions, write them in the chat box, even as the presentation goes along, because you might forget them by the end of it, and I'll keep an eye on them and will ask your questions. And if you want at the end, you can always put my favorite blue hand up, and we're being pushed to the top of the queue and ask your question in person. Okay, so Paul, please.
Thanks very much, Julia, and good evening, folks. It gives me great pleasure to basically introduce Deanne Jade to you this evening. As Julia's mentioned, she is the founder and director of the National Center for Eating Disorders, which is, I haven't got any hard data for this, but certainly in terms of my impression, is probably the largest training organization with regards to providing training specifically on eating disorders, as well as providing a major clinical resource for what is, I'm sure you're aware, is a major problem. It significantly overlaps with other difficulties that folks have. And not surprisingly, this has been recognized nationally, and Deanne's role has been recognized nationally as well. She's a member of the National Obesity Forum, Royal Society of Medicine, and the All-Party Parliamentary Group for Obesity. She was also part of the development of treatment guidelines for eating disorders and obesity by the National Institute for Clinical Excellence, NICE. And so I'm sure you're aware, she is a fabulous resource that we feel extremely privileged to be able to work in partnership with. As Julia's mentioned, and she'll probably no doubt say a little bit more about this later on, we're going to be running a particular two-day event on the use of Socratic questioning with eating problems, which I'll be leading next month. And I think that you know, Socratic questioning is a useful skill in many contexts. But I think that anyone who has worked with folks who have got eating disorder problems, you will know how easy it is, if you're not careful, to get caught up into some sort of tug of war with the client that you're working with, or alternatively simply go around in circles with them. And that issues of resistance, issues of risk are particularly pertinent with this particular client group. So we're looking forward enormously, as I hope you are as well, to some of Deanne's thoughts this evening as a precursor to the two-day event that we will be running next month. So, as I say, with great enormous enthusiasm, to be honest, I will pass you over to Deanne and allow her to take things up from this particular point. Welcome.
Thank you very much, Paul, and thank you for that amazing build-up. Let me share my screen with you without further ado and take you through my little presentation, which is about risk assessment for eating disorders, and take it from here. And as I was actually presenting this, preparing this little chat, I was thinking about, I'm trying to get it to move forward, hold on a second. I was thinking about 3 clients that I'd already seen that particular week. And one was Adam. He was about 40 years of age. He restricts, he's almost like a professional anorexic in recovery, male, single, And by contrast, there was Maisie, who is married with 3 children. What is interesting about Maisie is that she binge eats. She lives a fairly normal life and fasts in between binges and is overweight. She approached me for help with her binge eating, but she was clearly very attached to her fasting. It gave her a big hit. And there was someone else who, the screen is hiding my slide, so I forget her name, but she was about 30 years of age, single lady, working with a personal coach, intermittent fasting, intermittent exercise, and also very severely bulimic. So here we have 3 completely different clients that I had to assess, and I had to assess their risk and everything else. And although they seemed to be different, there was much that unified them. What unified them was that they were all subject to dietary chaos. They were all eating very abnormally. They all satisfied the criterion for having an eating disorder, which is their behavior was designed to control their shape and weight. Shape and weight was very important to them, and their behavior is harmful to physical and emotional health. And there are disruptions in what we call the ABC of normal eating. Then that's a big question, which I could talk more about at another time. But A stands for your mood around eating, your affect. Is it reasonable, or is it filled with shame and guilt? The B is the behavior. Is it flexible? Is it adaptive? And the C stands for cognitions. What are their thoughts? Are they obsessed with food, obsessed with weight? The answer is yes. And of course, normal eaters, they might be concerned about their shape and weight, but it's not forefront in their mind. And the interesting thing about them again is they all appeared fine. They didn't appear to be at risk, but they all in fact have significant risk. It's my job to find that out. So what do? We need to take a step back when we're assessing risk, because with eating disorders, what you see on the surface are what we call the symptoms. And the symptoms could include anything like weighing, reading diet books, purging, starving, feasting, fasting, avoiding carbs, pinching their body, stealing food, and ruminating all the time, spitting out food. That's what you see on the surface. What we know underneath happens with all eating disorder patients or clients. We can assume that they have some kind of deficits, not deficiencies, but deficits in coping. Common to all eating disorder patients, which I suppose you could say is risk, would be very poor self-confidence, high levels of sensitivity, difficulty with expressing and managing their feelings, not even knowing what they feel, and in some cases, very high association with trauma, but not for all the eating disorders. So we can make some assumptions about what people bring to treatment. Trauma, very common among people with bulimia nervosa, particularly. And again, in order to, we can make some guesses about what risk will be present. When we understand how an eating disorder is structured, we think of it as like an energy system, a toxic energy system, which doesn't necessarily have a single cause, so we don't have to look for that in terms of risk. But we think about predispositions, what leads to an eating disorder, and what keep people stuck. And here are some examples of the things that are keeping people stuck. And again, I ask you to think about these things through the filter of understanding what risk they bring to treatment. What maintains an eating disorder would be habits, very stuck habits, unhelpful thinking. An eating disorder, whatever it is, whether it's anorexia, bulimia, binge eating, night eating syndrome, there are lots of ways of having an eating disorder. It will have some payoffs. And the payoffs would include that the eating disorder somehow helps them either to block or regulate feelings. One of the questions we have to ask ourselves is, as well as this energy system, is there any comorbidity in terms, say, of personality disorder that could be maintaining, keeping them stuck, Or is there a comorbidity that is separate from the eating disorder that we have to be alert for? So when I see a patient like Adam or Marta or B, I have to, in the room, right at the start of therapy, do an assessment and assess the risk. And they're all different, but they will all have physical risk associated with their behavior, emotional risk, relational risk, because the eating disorder is going to have a profound effect on their family relationships, relationships with friends, and also something much deeper, because we tend to think of risk as just being present. What is the clear and present danger? But there are risks, much deeper risks to their future lives and the quality of their lives. What kind of life are they going to lead? How are they going to die? Are they going to die with their lives blighted by the eating disorder? So there's proximal risk, what's going on now, and there's distal risks. What is going to happen to the future? How is this going to affect the whole meaning and purpose of their lives? And how do we find out? I've been to many services where they think it's enough to do a standard kind of eating disorder scale, but that doesn't really crack it for me. And I like to think of an eating disorder risk assessment as being holistic. And it also includes some aspect of engaging with the patient or client, because shame about their behavior is going to lead them to withhold much of what is going on for them. So I have to show myself as being interested in the person, not just their behavior. Okay, so if I were to start with physical risk, which is easy, all our clients are sick. Even if they appear to be fine, they are not. Even a person with anorexia who will say, well, look, I'm fine. I can run 10 miles a day. I can run 5 miles. There's nothing wrong with me. I can go to school. I can do my studies. But they're very, very sick, because the eating disorder behavior causes harms. If we think about what people are doing, they're binging, they're fasting, they're feasting, they're purging, they're starving. They have macronutrient deficiencies. These will lead to very profound deficiencies in the body. The body is not this passive recipient of their behavior. They will be low in essential fats. They'll be having too much caffeine, Diet Coke, trying to cheat their appetite. They'll usually, if they're binging, be having a lot of simple sugars, insufficient fiber. That is going to have an effect on the body, as shown on the slide. The body will be in a state of inflammation. There will be endocrinal, skeletal, metabolic, digestive, neurological impairments, some leading to profound sickness, and in the case of younger people, to delayed development. And not only will it affect the body, but it will help us understand some of the symptoms that people bring to treatment. They will have cravings because of imbalances in their brain. They will be tired, depressed, have sleep problems. They'll be lethargic, angry, impulsive, and very, very anxious. And it isn't only because of early childhood adversity. This is the physical effect of their behavior. And again, neurologically, diet will be affecting some of the neurochemicals that affect mood, hunger, appetite, metabolism, and emotional functioning through effects on serotonin, endorphins, dopamine, cortisol, insulin function, and the metabolic hormones. So the physical effects of behavior are profound and usual. So how can we know what actual risk the client is suffering? Some are going to have a bigger risk than others, but some people are very sick, even if their weight is not necessarily low. We associate high risk with low weight. This is not the case. Yes, with anorexia nervosa, there's a very high risk of death. It is still the eating disorder with the highest death rate of all the mental health problems. But death rates are also very high in bulimia nervosa and as a result of compulsive eating, which may shorten life by a number of years if it is also associated with obesity. So how are we going to find out? Well, we have a questionnaire we give people before they come, and that has a symptom check. And we also do what's called a functional behavior analysis with people. We get them to fill in a food diary before they come. Doesn't matter what the presentation is. And yes, I know they may not tell the truth, but often they do because we tend to ask the right questions. So we find out what they're doing, how they're eating. I was shocked looking at the food diary of someone who came to see me to find out that this person was drinking 6 liters of water a day. She was extremely ill, and my recommendation was that she get to A&E immediately, as soon as this session with me was ended. So we have to, to some extent, if you're working with eating disorders, you need to have an enormously good understanding of physiology and nutrition and neuroscience in order to be able to assess risk safely. But clearly, there's some aspects of risk we can't check, and we have to send a patient to a GP if we think there's a problem. If we assume there's a problem, it's dangerous to take chances because some of our compulsive eaters might be diabetic, they might have thyroid problems, and some people with anorexia who appear to be ill might have very dangerous symptoms like bradycardia, which is a slow heart rate, which can lead to death. And some normal weight people who appear to be doing their lives perfectly well, but suffer from bulimia nervosa, might have serious electrolyte disturbances as a result of taking laxatives or purging, which means they're at imminent risk of epilepsy or a heart attack or kidney damage. So it's very, very dangerous for us to take a chance. Where emotional risk is concerned, we need to remind ourselves that eating disorders share features with many other mental health problems, which Paul has already mentioned. Sharing features with addictions, because there's addiction-like features of eating disorders where people say, I've got to get my fix, or they become tolerant to the effects of certain food, or show symptoms of withdrawal if they don't get their favorite treats. There's a lot of obsessive behaviors we show up in eating disorders. There's also depression. People with eating disorders are invariably sad. It's very difficult to have an eating disorder in your life and not be damn miserable, and also feel that you're full of shame and remorse for your behavior. And there's also delusions in eating disorders. After all, when someone who is skeletal tells us that she's fat when she's actually very, very thin, it does seem like a kind of psychotic position to be in. And people with anorexia hear a voice. Some of you may or may not know that. They actually hear a disembodied voice telling them that they'll feel better if they eat less, or telling them that they're really bad if they eat anything at all. And that does seem very psychotic to me. So although eating disorders share features with all the other mental health conditions, including anxiety disorders, it is not just a variant of these disorders, but someone might have another mental health problem as well as an eating disorder. So the question there is, how are we going to find out what's really going on as part of our risk assessment? And we have a problem here because some of the emotional symptoms that we see in the room, and we do have a checklist on our questionnaire of how people are feeling at this current point in time, are simply state dependent. And that means they are a direct effect of dietary chaos and other behaviors. So features like obsessive thinking, impulsive presentation, high levels of rage and depression, and other emotional symptoms are simply the effect of what you're eating and what you're doing, and are not caused by early adverse experiences. And this again calls on the need for an eating disorder specialist to understand the effects of food and activity and other behaviors and mood. So the kind of things that people bring to therapy look primary: depression, anxiety, low self-worth, hopelessness, and suicidal feelings. And we have to figure out what is really going on for several reasons. One is, does it need to be treated? Is it just the effect of diet and behavior, or is it going to interfere with therapy, such as a personality disorder might, or post-traumatic disorder might? So the question, how can we find out? Again, a good qualitative questionnaire. And something that I really like, which I'll show you in a minute, which is called a weight and relationship transitions lifeline. This is something I learned initially from a very famous eating disorder specialist called Christopher Fairburn many years ago. I'm not sure that he does it now, but I do. And we can also ask carers and families what their impressions are, how they experienced their loved one over time, something that we might not be able to pick up, because some people, when they come in the room, are fairly silent because they don't quite trust us yet, and because they're full of shame about their problem. They don't always open up immediately. So we also need informed observation when we're sitting in the room with people about their demeanor and their expression and their emotional response to the kind of questions that we are asking them. But I don't do any formal scales. It isn't really necessary. So let's have a look at what I do. And this is an example of a weight and transitions lifeline. It isn't the only thing. It takes time. You need a lot of practice doing it, and you use symbols. And one of the reasons why we use symbols when we assess someone with an eating disorder is that we have to assume that they have some emotional deficits which make it very difficult for them to describe their emotional experience. In many cases, people with eating disorders don't know what they feel. And so it's not very useful to ask them. They'll often just go into fight, fright, or freeze, and they will not be able to engage with us. So by using symbols or metaphors, we can often get a good example of what's going on. I don't want to spend too much time talking about this particular client who was, had gone through many iterations of different eating disorders before she came to see me, where she had become very compulsive following a period of dieting, and then she's had a period of anorexia. She had developed bulimia, her weight had risen, she had stopped purging because she caught her child trying to purge, and then she became deeply compulsive, and on presentation, she had already gained about 90 pounds in weight and was desperate to stop binging and lose weight when she first presented for treatment. So this kind of lifeline will sometimes pick up not only trauma, adversity, but give us an indication of someone's coping skills, not only the deficits they bring to treatment, but also their resources. I'm very much on the side of learning from clients what their strengths are, not just their emotional incapacities. and also how they've done relationships. It's also very useful to ask a client as part of an emotional risk assessment what their current stress is. What is the biggest stress they have in their life other than the eating disorder? Because sometimes as part of a risk assessment, you may need to prioritize in treatment some other thing. And the kind of things that we may need to prioritize, for example, could be a severe relationship problem they're going through, a stress at work, which could interfere with treatment, or trauma. And we do know that if someone has experienced a trauma, which we can pick up through lifelining and through a good story taking, the treatment of the trauma is not going to cure the eating disorder, but it will interfere with treatment. And about 80% of our bulimic clients suffer from full or partial PTSD. Interestingly enough, not the people with anorexia nervosa. But clearly, as part of our lifelining work or the targeted questions in a good questionnaire that people can do before they come to see us, we can pick up things like substance abuse, either current or historical, that may actually be important because that in itself would have created some neurological impairments. We can pick up autism, which is very common in anorexia nervosa. No use rushing into treatment. If your client is neurodiverse, you will have to build some of that into a treatment plan. And you obviously need to know if your client is psychotic or has some other mental health illness, which means they're not going to do well in treatment for an eating disorder. And we have had quite a few of those. So the questions we're asking is, what is comorbid? What is going to interfere with treatment? And so importantly, what is it going to affect their quality of life other than the eating disorder? And the reason I ask that on a risk assessment is that part of the treatment for an eating disorder is not just taking the eating disorder away. Our job as eating disorder specialists is to build something bigger than the eating disorder, to help someone flourish, not just to take away their symptoms. That doesn't kind of do what we promise on the tin. So I've done a whistle-stop tour through risk assessment, but there is a summary which is important. An eating disorder psychotherapist needs a huge amount of CPD to work effectively, not only as a treatment guide, sponsor, or mentor, but we also need, as part of our job, to assess risk, full understanding of many different things. We need to understand physiology, the effects of dietary chaos, the effects of poor nutrition, to alert ourselves about physical risk, as well as making some assumptions through our CPD and learning of what we think people are going to bring to treatment who suffer from the disordered eating and its correlates in terms of other behaviors. We also need a variety of therapeutic skills to understand emotional risk and to be able to separate the effects of dietary chaos on mood and emotional presentation from the other problems that people might bring to therapy that might need separate treatment or might interfere with treatment. And as part of risk assessment, we must be thorough, holistic, and we must be able to engage person to person with the client in the room so that they will have the confidence that we know what we're doing and that they can trust us to share what they might want to be keeping secret about their symptoms, because they're scared of engaging in therapy in case it makes them fat. They may be hiding things that could be dangerous. The picture that I've put on the left-hand side of the slides really tries to state what this is about. The eating disorder patient has one egg in the basket. That is their concerns of shape and weight and the behavior and the emotions and the thinking that goes along with it. It pushes out all the other eggs that leads to a meaningful life. As part of assessment and part of risk assessment too, we need to communicate to our clients that we're interested in helping them to thrive, to have a lot of eggs in their basket, not just to take the one egg out. And on that point, I would like to say thank you for listening to me. It was a whistle-stop tour through actually quite a complicated subject, and I would be delighted to answer any of your questions if you have any.
Thank you, Deanne. I don't know if you can hear me. Yeah,
Yeah.
my phone is working. Yeah. Thank you, because it was playing up a little bit. Thank you very much, Deanne. I will give you a few moments to type up your questions in the chat box, or as I always say, you can put your electronic hand up and I will stop sharing the screen. I will just help you to find the Socratic questioning for eating disorders course on SDS website. So if you go, I'll share my screen. Yep. If you go to SDS website, you click on all courses and you either type here Socratic or questioning or eating disorders, whatever you want to type, or you can go to calendar view here, and the course is taking place on the 29th and 30th of June. It is a 2-day course on Zoom, but it is 2 full days. It's not a shortened course or anything. It's 2 full days on Socratic questioning. And also this course can be taken as part of Master Practitioner Diploma in CBT. So if you're working with eating disorders and you want to do specifically Socratic questioning for eating disorders, you can count it to your overall diploma. Okay, so that's how you find it. And it's still an early bird price, by the way, 245. So it's a very good discount. Do act quickly, because let's check when it expires. And it expires on the 29th of May, so only 2 days left of early bird discount. So do take advantage of that. So I'll stop sharing, and
I've had a look at the chat and I can pick up some of the questions.
Absolutely, go ahead, Deanne.
Okay, thank you very much for those who've put nice comments. Glad to be of service. Right, so I'll just pick one because they're flicking up and I can't see them all in order. So Paul and Julie can help me out with that. The one that's someone has said, how do you consider abnormal exercise behavior with risk assessment? Haha, well, that's quite an interesting question, because we will ask about exercise or activity. And it's very hard to know what is abnormal, because a lot of people say, well, me, I just kind of love to run marathons. And we have to decide to what extent the exercise is harmful and to what extent it isn't. And people will argue very violently with me, because the problem is with exercise that exercise is generally deemed to be a good thing. Would you not agree? And therefore people who do a lot of exercise, who also have eating disorders think they're doing a very good thing. There is a condition called REDS, which is relative energy deficiency in sport, where people go into underloading calories, and that can actually affect their entire endocrine system. They get hormonal problems. Men have a tremendous fall in testosterone, osteoporosis, and women don't become infertile and lose their period. So the thing is that when you have people doing something they think is a good thing, it doesn't behove me to tell them that maybe it is not very helpful. And exercise addiction is one of the things that we have to look out for, and we have to engage in a very careful conversation with people to make sure that if they're doing exercise, that they're not doing it as a form of self-harm or as a form of a way of reducing calories, because actually it really doesn't. All it does is affect the body in quite horrific ways. If someone's doing exercise because they love it and they're eating for their exercise, that's something else entirely. So you've asked me a question I could probably take about 2 hours to answer. But if I had to answer quickly because there are other questions too. Is that okay for the moment?
Yes.
That's part, we do get, we're very, an eating disorder specialist or an obesity specialist also needs CPD in exercise physiology, and I've had to do that too. So there you go.
Thank you, Deanne. There's a lot of questions. Why I suggest, Paul, you pick up one to ask, and I'll pick up one as well. Oh, you were relaxing there.
Just one. Okay.
So there's lots of questions, and we need to somehow work together on them. So
yeah. Okay. Okay. Well, let's just dive in. We have a question here about, and I know this is very difficult to answer briefly, but any tips at least about how you might adapt therapy for someone with an eating disorder who is autistic?
Indeed. Interesting, really interesting question, because we've now discovered that autistic function, actually I don't like autism, it's simply neurodiversity, and we look for poor central coherence. There is actually tests that we can do to find out about central coherence, but there are clues, and one of the clues is something called haptophobia, where someone has fear of being touched, and also problems with noise and feeling in childhood that you don't quite fit in, and being very rigid. So we know what to look for. We don't label people, but sometimes people get quite excited if we can validate their prior difficulties coping by the fact that they might be neurodiverse. They can actually get quite excited about it and say, oh, I'm not a sick person. That explains everything. But we have to adapt it. And what we can do is something called cognitive remediation. And that was something else where we can help people to free up their rigidity. We can help them to stop focusing on detail and look at the big picture. We be able to step back, look at things from different perspectives and not just one way. And it is slow, but it's very valuable as well. So that again would require a bigger answer, but an eating disorder specialist ideally should be trained in a form of psychotherapy called cognitive remediation, which is really useful for autistic presentation. I think what it is it's a bolt-on that is really useful.
Thank you.
Thank you.
Eva asked quite early, what exactly do you mean about by personal predisposition to eating?
Very interesting. Yes, when it comes to an eating disorder, we think that we take a no-cause position. Eating disorders are associated with dieting, but not caused by dieting, because we find a diet present in the history of most people with any form of eating disorder, except for about 5% who start eating in a context of trauma, a very small number. But instead of cause, we look for what we call the 3P model, where the first P would be predisposing factors. What predisposes someone to get an eating disorder? It's usually hypersensitivity, it's usually higher than usual levels of anxiety, and some problems with emotional processing. You know, so low self-esteem is one of the factors as well. One thing I can say maybe you'd like to think about this, is that people who don't get eating disorders are invariably those who have high self-confidence, who seem to be good at getting friendships, who don't worry too much. Whereas people who get eating disorders are invariably sensitive, perfectionist, higher than usual levels of anxiety, and they will have had shape and weight sensitizing experiences in their early life. It could even be mothers who diet, fathers who make comments. It could be anything. These are the predisposing factors. Once you know what they are, you can find them easily when you do a history. The second P is what precipitates or kicks the eating disorder into life, which is usually some form of stress at a time when someone is not coping very well. And the third P is the perpetuating factors, the things that the energy system that someone is trapped in the middle of, keeping them stuck. And treatment lies there, not in cause. I hope that satisfies your answer. Again, I could talk for a day about that.
Paul?
Yeah, I was very struck, and I don't know if I've actually read this anywhere else actually, but I was quite struck by what you said about the association between trauma and PTSD and bulimia, but not so much with anorexia. And I guess just wonder what your thoughts were really, or speculative thoughts were on what that's about.
I think we do know from research, again, the references are available, that about 8 out of 10 people with bulimia nervosa, that is normal weight, but binging and purging to avoid weight gain as a result of binging. There's many kinds of eating disorders. There's a form of bulimia which is not, it's called purging disorder, and it's not purging to avoid weight gain. But about 8 out of 10 people satisfy the criterion for having full or partial syndrome PTSD. But Paul, the interesting thing is that the trauma in this case is not sexual abuse. It is in the form of usually abandonment or neglect. So that's interesting, and that merits another discussion. Now, when it comes to anorexia or binge eating disorder, I can qualify that. I do think that anorexia nervosa has a history of trauma. We think, and I've got to try and keep this answer brief, that anorexia starts a very long time before the symptoms show up. When you understand eating disorders really well, you'll see anorexia or anorexic-like behaviors exist well before weight is lost. And what is invariably present in anorexia nervosa is perfectionism. And when you live with perfectionism from a very, very early age, you're experiencing high levels of stress almost from the time you're born. High sensitivity, high anxiety, and perfectionism. We call that the evil trio. You try living with that from childhood, and then you end up in what we call a state of prolonged duress, which is very similar to post-traumatic stress disorder. I think that when people have measured PTSD, they haven't quite taken that into account when anorexia is concerned. But when it comes to binge eating disorder, whether or not a person is overweight, there is no greater risk of trauma being present in the history compared to people who do not have binge eating disorder, who eat normally. There is one exception. People with binge eating disorder who are also morbidly obese, that small cohort among those people with binge eating disorder, not all are obese. They have a much higher risk of emotional pathology in the form of mood disorders, psychiatric history, substance abuse, and trauma, but not all. People who binge eat, who are normal weight or slightly overweight, do not have that risk. That's why I'm saying it's easier to assume risk, Paul, or to think maybe when you actually know the research behind the presentation. Does that make sense?
Yep. Yep.
Well, another question, quite an early one. Are eating disorders commonly seen with self-harm? And I would probably add, or seen as self-harm.
Well, let me ask. Some of these questions are so great. I'd like to go down a rabbit hole, and I daren't because we don't have time. However, if self-esteem is low, the behavior patterns that tend to follow that could take three forms. One is self-abuse, the other is self-neglect, and the other is over-control. You see all of these patterns present in eating disorders. So clearly one of our targets is to help to boost self-esteem and the associations which could be self-efficacy, the I can do this muscle, and so on. However, not all eating disorder behaviors are self-harming, not all. And I think it takes observation.
It's a phrase.
Self-harm, and laxative abuse rather than purging is definitely associated with self-harm. Laxative abuse, but not purging. You see, people start off purging by accident, more or less, vomiting. They think it's something that will help them. And then somehow it changes, and it becomes, because of its associations with mood change, it becomes a way of managing your emotional life. It is not necessarily a form of self-harm, but we always have to look at the possibility. And one of the things we do as part of treatment is boost self-harm and do things, do things, not just talk. Eating disorder therapy is not just a talking therapy, it's a doing therapy. And we have to get people practicing forms of self-care so that that element of their behavior, which could be self-harm, is reduced.
Thank you. And I wanted just to ask another question, which Maria just posted in response to what you said earlier. What would you recommend for children who are identified at early age with high perfectionism, high sensitivity, and high anxiety, that group of risk of developing anorexia?
Fabulous question. If this is part of a child's nature, you cannot change nature, but I am excited to report there is something that can be done. And what can be done is lateral to your question. We know from work that's been done in the States that if you give children an emotional vocabulary from a very early age, the chances that their intrinsic deficits or vulnerabilities will not convert into mental health problems as they grow up. So by that, I mean, if you teach children a wide range of names for feelings, number one, and you help a child connect what's happening in their head to what is happening in their body, where we experience emotion, and they can name those emotions with as many words as possible, including non-English words if necessary, then it acts as protection against mental health problems in later life.
Thank you very much. I know we've got many more questions, but we are right up against it with the times. And I just wanted to say that Deanne is a fabulous presenter, and I've done training with Deanne myself, and I can highly recommend her training courses. And just go on her website, search for Deanne Jade or National Center for Eating Disorders, And I don't often do it, Deanne, recommending somebody else's courses on SDS Thursday, but genuinely, if you have more questions, just go and train with Deanne. I did find it incredibly useful. And thank you very much again for coming. I do ask you also to come to Socratic questioning for eating disorders with Paul, because Deanne found Socratic questioning is incredibly useful for patients, clients with eating disorders, and not necessarily often taught. So we hope to see you again on SDS courses, on SDS trainings, and thank you very much again, Deanne, for coming tonight.
Thank you, Julia. Thank you, Paul, and thank you everybody else for listening.
And you can unmute yourself and say goodbye and wave your hands. It's always a very nice moment at the end. Thank you.
Thank you.
Take care, folks.
Bye. Thank you.
Bye-bye.
Thank you.
Thank you.
Really
Bye.
good.
Take care.
Thank you. Bye.
Thank you.
Thank you very much.
Bye. Thank you.
Take care.
Thank you. Bye. Bye. Thank you.